It gives me great pleasure to welcome our next speaker, Dr. Reji Mohan, Associate Professor in the Department of Reproductive Medicine and Surgery at Government Medical College, Trivandrum. He will be speaking on the topic, newer protocols for ovulation induction in PCOS. Let us warmly welcome Dr. Reji Mohan to the stage. Over to you, Doctor.
Good afternoon to all. I'm asked to present on newer ovulation induction protocols in PCOS. First, let me pay my sincere thanks to the team Advances 25, Dr. Jageshan sir, Niranjana, Ashwin, and the Trivandrum OBGYN Club for this fantastic conference, 25th year, spreading knowledge, spreading light. Thank you very much. So, first of all, let me put a disclaimer first. There is nothing much in the ovulation induction protocols in PCOS. So, this will be my outline of my talk. And as all of you know that the PCOS is the most common endocrine disorders affecting the reproductive age group women all around the world, and the incidence is around 5 to 15%, and 1 in 10% face this issue before menopause, and 36% of women in India suffers from PCOS, and the prevalence in India in the infertile woman is around 15 to 20%. So what we see usually is just a tip of iceberg in polycystic ovarian syndrome. So there are so many other things, and you need a multidisciplinary team approach to see each and individual problems with the polycystic ovarian syndrome. So I'm asked to talk about the ovulation induction in PCOS. So coming to that, first of all, you have to see that it's a preconceptional thing. So always try to consider and optimize the blood pressure, weight, smoking habits, alcohol, sleep rhythm, mental habits, all those things. And you have to be definite about the prenatal vitamin status, and folate supplementation is very important. And what you have to notice, if it's an obese woman and all, she may require a higher dose of folate, exclude pregnancy before ovulation induction, and tubal patency test it should be decided on individual basis. So lifestyle modification goals are always there. In 2018 guidelines, the goals were SMART, that is a specific, measurable, achievable, realistic, and timely. Now they have added E and R, that is the goals have become smarter. So you have to re-evaluate yourself, and also you have to re-evaluate whether they are sticking on to the goals. So optimizing body weight as well as diet modification is of utmost importance in polycystic ovarian disease, and all of you know that minimum weight loss of 5% in obese women will lead on to a reduction in the hyperinsulinemia, increase in the insulin sensitivity, restore the ovulatory cyclicity as well as fertility. This will definitely improve the reproductive outcomes, hyperandrogenic and clinical and biochemical features of the lady. So the fitness mantras, usually some physical activity is better than always none. Limit the amount of time spent in front of a screen. Fitness tracking devices and technologies to count the step count as well as exercise intensity. And always your goal should be lifelong health strategies. So coming to the medical management of ovulation induction, all of you know that the first line is always the aromatase inhibitor, that is the letrozole. It acts by aromatase inhibition, usually starts after 2 days of your therapy, and it decreases the estradiol level and increase the intra-ovarian androgens, which lead on to a monofollicular development, which is very particular to the letrozole. And the usual starting dose is 2.5 milligram daily. You can increase up to 7.5 milligram if not responding. So second line is the clomiphene or the serum estrogen receptor modulators. Start with 50 milligram. These are all basics. 2 to 5 days of start, empirical incremental in the titration, and usually go up to 100 by FDA. You may some societies recommend up to 150 milligram. 6 cycles is usually more than 6 cycles is undesirable, and you know that more than 80% ovulate, but only 40%, 30 to 40% conceive because of the anti-estrogenic effect of this clomiphene. And again, there is definitely an increase in the incidence of multiple pregnancies. Adjuvants, why there is a need of adjuvants? You know that there is because of resistance is there. Sometimes there will be insulin resistance, hyperinsulinemia, androgen excess, obesity. All these things may need your adjuvants like glucocorticoids, metformin, ionisitol, NAC, melatonin, vitamin D, and chromium polynicotinate. So insulin sensitizers, the time-tested one, that is the metformin, that is a biguanide, oral anti-hypoglycemic agent. The dose usually you start with 500 milligram, you can go up to 2,500 milligram per day. So coming to the next strategy, that is the laparoscopic ovarian drilling. This is how the laparoscopic ovarian drilling acts on the ovaries. So many actions are there, but nowadays many of them many of us are refraining from laparoscopic ovarian drilling. So stick on to the rule of 4, that is 4 puncture, 4 seconds, 4 millimeter, 40 watts, monopolar or laser, and hold in the antimesenteric order, and you have to saline irrigate to decrease the temperature after your puncture. So usually it will restore the ovulation in almost 63 to 85%, and beneficial effects may last for years in this woman. So gonadotropins, again, it is the second pharmacological line. Anything will be that is FSH, HMG, highly purified, urinary, not much of difference. Cost always to be considered. USG monitoring and expertise is needed. Always a preferred one is the low dose step-up protocol. You need counseling especially regarding the cancellation policy. And again, the clinical efficiency between the gonadotropins, there is no difference. So coming to what is new in ovulation induction, what is new in the letrozole is, I will be coming to one by one. This is a paper published by Rachel Mandelbaum in 2024. A comparison of letrozole regimes were done for polycystic ovarian syndrome. Like she compared 2.5 BD for 10 days, 5 milligram for 5 days, and 5 milligram for 10 days. So what the study has concluded is to start, the 2.5 milligram is gives inferior response. Second thing is you may need a higher response or an extended duration of letrozole sometimes. And ovulation rates have improved when starting a letrozole at 5 milligram per day or a 10-day extended course of letrozole. So that is what the study says. And letrozole resistance is almost in 15% of patients. 15% of the patients fail to ovulate with letrozole. And always think again what is the matter. You think of your thyroid abnormalities, you think of hyperprolactinemia, think of hirsutism, 17-hydroxyprogesterone, you may be missing late onset congenital hyperplasia, virilization symptoms, ovarian insufficiency, and of course GTT if the patient is obese. So this paper again published in 2023 was done for predicting the response of ovulation induction to letrozole. Again, this study showed that cumulative ovulation rates were significantly lower when the menarche was attained more than 13.5 years. LH-FSH ratio was more than 1.83. AMH, if the AMH was more than 9.78, and the free androgen index of more than 5.99. This is some predictors of the response to your ovulation induction. So whenever there is a letrozole resistance, the options are the extended letrozole regime, the step-up regime, clomiphene plus letrozole regime, sequential regime, stair-step, adding dexamethasone and adding metformin. Coming to one by one, that is the extended protocol. That is, you start the letrozole 2.5 milligram from day 1 to day 10. You monitor. Then this has resulted in higher pregnancy rate, higher multifollicular ovulation, better endometrial thickness, and maybe done for timed intercourse or even in IUI cycles. So these are some studies. This was published in 2008. The latest study is in 2024. Again, they also confirmed that extended letrozole is a feasible method of ovulation induction in women with PCOS as well as letrozole resistance. So step-up protocols, again, they have started from 2.5 milligram on day 2, 5 milligram on day 3, 7.5 on day 4, and 10 milligram on day 5. This is what's called step-up. Again, they have found that there was increased pregnancy rate, increased multifollicular ovulation, better endometrial thickness, as well as good for timed intercourse as well as IUI cycles. So coming to sequential protocol, that is you are combining letrozole or clomiphene with HMG or FSH. You start with 2.5 milligram BD on day 7, day 8, day 9. You add on HMG or FSH, which resulted in significantly higher ovulation rate. And always, what you have to be worried is the multiple ovulation and multiple pregnancy rate. Again, the study has shown that sequential letrozole plus HMG protocol may be superior to letrozole alone protocol in terms of ovulation induction and pregnancy promotion among infertile women with PCOS. So this is another study which they compared the 2.5 milligram letrozole dose with 5 milligram letrozole plus FSH dose. Again, what they have found out was, again, the minimal dose of 2.5 milligram letrozole with FSH is more effective than the sequential letrozole of 5 milligram plus FSH for promoting pregnancy as well as ovulation. So coming to the stair-step protocol, again, that is a new finding. That is, you start with 2.5 milligram or 5 milligram for 5 days from 3 to 5. You call her back on day 10. You're seeing a thin endometrium, no follicular development. You can see you can increase the dose to either if it is 2.5 to 5 milligram or 7.5 milligram without waiting for a withdrawal bleeding. So that is called a stair-step regime. So this has found that your ovulation rates has increased up to 90% in a stair-step protocol. So these are some studies which shows that the letrozole as well as clomiphene can be used as a stair-step protocol. So you start with 50 milligram. Suppose if it is clomiphene, go for 100 milligram on day 10 if there is no response or if the endometrium is thin. So that is regarding the letrozole step-up protocol was efficacious as clomiphene citrate stair-step protocol, and there it's a comparable effects of ovulation as well as clinical pregnancy. And what they have noticed is the time to ovulation was shorter when compared to the routine letrozole protocol. So the thing again, this is another paper which has shown that this stair-step protocol was a safe approach to ovulation. It shortened the time of ovulation, increase in the endometrial thickness without increasing the risk of hyperstimulation or multiple pregnancy. So again, another thing is you give 20 milligram of letrozole stat on day 3, and it was compared with 2.5 milligram into day 5. So again, there are several papers. This was again published long back in 2005 by Mitwali. So again, this has re-emerged in letrozole resistance you give, and this can be considered as an alternative to your letrozole usual protocol. So you give a single dose of letrozole of 20 milligram on day 3 and watch for ovulation. So the new thing is you combine letrozole with clomiphene citrate. So what is happening is, you know that the mechanism of action of letrozole and CC is different, so they can have a complementary effect. You start both letrozole and clomiphene citrate together and monitor. They have found that this combined therapy has promoted a significant benefit of maturation of follicles and ovulation with similar safety profile compared to letrozole. So this is another option, that is adding letrozole and clomiphene citrate together for ovulation induction. So this is a study which is again published in 2018. So adding dexamethasone usually we do. So whenever there is a clomiphene resistance or letrozole resistance, definitely you can add 0.5 milligram of dexamethasone, and they have found that improved ovulation rates with this regime. So letrozole you can have 2.5, 5 milligram. All these regimes have been tried and tested and is found good in letrozole resistance. Coming again, the Cochrane database, again they have showed that letrozole is the drug of choice for ovulation induction in PCOS. It improves the live birth rate, pregnancy rate when compared to CC, which been used for ovulation induction followed by timed intercourse, and there is no difference in miscarriage as well as multiple pregnancy rate. So what's new with clomiphene? Again, I'm having a disclaimer, that is there is nothing new. So you time tested, that is clomiphene resistance and clomiphene failure, all of you know about that. So again, you have to investigate or you think of why this clomiphene failure has happened. So again, a high free androgen index, high BMI, high LH, insulin, all this can cause clomiphene citrate failure. So strategies, usually you have to monitor for the anti-estrogenic effect. You add adjuvants like HCG, dexamethasone, laparoscopic ovarian drilling you can think of, other regimes you can think of, and of course gonadotropins. So again, what is new in that LOD? This is a recent paper in 2023, ovarian drilling, back to the future. So here again, they are advocating ovarian drilling in cases of more than 20, if the BMI is more than 25, low basal LH, and more than 3 years of infertility, more than FAF, more than 15, again a high basal AMH and all this, they have found benefit. This LOD or laparoscopic ovarian drilling has been beneficial in this patient. So what is the new kid in the block is is you can go for a transvaginal hydrolaparoscopic ovarian drilling, or you can just do a ultrasound guided transvaginal ovarian needle drilling. These are the two entities which is coming up. Again, coming to the insulin sensitizers, again a number of drugs are available like metformin, thiazolidines, inositols, alpha lipoic acid, GLP-1 analogs, all those things. But the thing is, the metformin stands good. So again, metformin is indicated in more than BMI of more than 25, mild side effects only. You start with 500 milligram. Especially you have to note that there will be low vitamin B12 levels you have to keep in mind. So this is a study published in 2025 actually. So all the PCOS women with impaired glucose tolerance can be started with metformin. Obese PCOS with along with clomiphene citrate. Again, with those who are at high risk of ovarian hyperstimulation, you can add on metformin. Again, continuing metformin till the end of first trimester has shown that there is a reduction in the rate of miscarriages. So coming to the gonadotropins, nothing much. Always stick on to the chronic low dose protocol. So gonadotropins are always considered as a second line, either considered alone chronic low dose protocol. You can consider as a sequential regime with either with clomiphene or letrozole, and always think of adding metformin if she is an obese or an abnormal GTT patient. So again, whenever you are starting on gonadotropins, you have to think of the cost of the intervention, the expertise required for scanning, then the degree of intensive ultrasound monitoring. Always stick on to the low dose step-up regime, and implication of potential multiple pregnancies, as well as you have to counsel them regarding your cancellation policy. So suppose if there is more follicles, there is a chance of multiple pregnancy, there may be a chance for cancelling the cycle also. You have to counsel the patient. So coming to one of the paper published in 2024, again the Bambini trial. So what they told is this bariatric surgery and ovulation induction after vertical sleeve gastrectomy. Again, they have found that the ovulation rates have increased or more effective in patients with more than a BMI of more than 35. Spontaneous ovulation has happened. So this bariatric surgery could therefore enhance the prospects of a spontaneous fertility in group of resistant PCOS or the patients who are resistant to all the drugs for ovulation. So lean PCOS is another thing. So what I have found in this paper is there is nothing much. But again, ovulation induction are the same thing. What they suggest is lower the consumption at dinner, elevate calorie count at breakfast, maintain a weight, that is most important, supplement with micronutrients, resistance and exercise. Always tell them that you shouldn't increase the body weight. So they have to do resistance exercise, and they have to maintain the weight in lean PCOS. So elagolix is the new kid on the block. Again, you can see that oral elagolix is an oral GnRH antagonist. When this trial was done, phase 2 trials are going on, or I think just finished. So what they have found out that in patients with premature luteal surge, sometimes you may say at 12 millimeter or 40 millimeter, suddenly the follicle disappears. So in those patients, you can try oral elagolix, 150 milligrams starting from when the follicle reaches around 12 to 14 milligram. You can start elagolix, and they have found that you can avoid this premature luteinization as well as premature luteal surge. But again, clinical improvement in the clinical pregnancy rate they have not yet documented. Future prospects, again, you can see there are so many drugs in the pipeline. That is fezolinetant, which is a neurokinin 3 inhibitor receptor antagonist. Kisspeptins are on the way, and there are a lot of papers on probiotics, prebiotics, and symbiotics. Again, newer anti-diabetics are also under research. So these are the future perspectives. And this is again, I found this study study which is debatable actually. This was published in 2023 by Human Fatemi and Barbara Lawrence. So what this paper says that ovulation induction in anovulatory infertility women is obsolete. So why? Because ovulation induction can cause multifollicular response, higher order pregnancies, increased time to pregnancy, increased maternal age, and obligatory intercourse. You are forced to have sex. So what Fatemi has told is, if you are going for IVF, it's an individualized IVF with cycle segmentation, freeze-all strategy, and single embryo transfer. You are increasing the rate of pregnancy to up to 83% success, and there is a reduction in multiple pregnancy rate. And once you finish 3 completed cycles, there is a good success rate of 83%, and there is less exposure to the fertility drugs, and as well as there is shorten time to pregnancy. So what he has suggested is rather than with the availability of highly sophisticated individualized IVF treatments with low complication rates, high success rates and reduced time to pregnancy, patient nowadays might not be willing to accept the time consuming ovarian induction treatments and higher multiple pregnancies. So it has come to a time the time has come to replace ovulation induction in anovulatory cycles with IVF treatment, including cyclic segmentation, single embryo transfer in an FET cycle. So, to conclude, the diagnosis of polycystic ovarian syndrome is the most important thing. You always follow the standard algorithms. This is the algorithm published in 2023 by the Monash University. Again, IVF in PCOS is nowadays safe with the advent of segmentation. Future is bright. So many new drugs are coming up in the pipeline. Thank you. Thank you for your patient hearing. Thank you.